Hey everyone, and welcome back to another episode of the Bulletproof Hygiene podcast. Today, I have the immense pleasure of interviewing our own SPODAC oral and maxillofacial surgeon, Dr. Jason Sheikh, about pre-medical guidelines, medical clearance, as well as how to respond to and reduce risk for medical emergencies in the dental office. So Dr. Sheikh, I want to give the listeners some insight into who you are and why you are an expert on these things. So Dr. Jason Sheikh is a Florida native who was born and raised in Boynton Beach. He attended the University of Miami for his undergraduate studies, continuing on to receive his dental degree at the University of Pennsylvania and his medical degree at the Econ School of Medicine at Mount Sinai. Did I say that correctly? Is it Econ? Icon, okay. He completed his training as an oral and maxillofacial surgeon in a 6-year residency at the Mount Sinai Hospital in New York City before continuing on to complete a fellowship in cleft and pediatric craniofacial surgery in Charleston, West Virginia. Dr. Sheikh is actively involved in the community and has recently attended multiple mission trips to Mexico, Nicaragua, Bolivia, and Guatemala with the goal to provide care to those who otherwise would not have access to it. He enjoys the challenge of providing care to a range of patients who have medically complex cases and looks forward to helping all of his patients achieve their SMILE goals. His academic achievements have included writing multiple manuscripts and presentations on pediatric pathology and trauma, and he has also been published in the Journal of Oral and Maxillofacial Surgery and Clinics of Oral and Maxillofacial Surgery. So thanks so much for devoting some of your valuable time with us today, Dr. Sheikh. Before we really jump in, I want to provide some data and information about some of the most common medical emergencies in a dental office. And then we're going to kind of circle back and pick your brain about how we can apply some practical things for preventing and solving these issues when they do occur. So according to the British Medical Journal, medical emergencies that have occurred in dental practices include vasovagal syncope, angina, hypoglycemia, epileptic seizures, choking, asthma, anaphylaxis, and cardiac arrest. It's estimated that on average, a general dental practitioner, GDP, will experience a medical emergency at least once every 2 years. Vasovagal syncope is the most common emergency encountered. And interestingly, one study showed that 4.8% of all general dental practitioners observed the crazy number of 22% of all syncopes, and that the prevalence of vagal syncope tends to decrease with professional experience, so patient management. Risk management can play an important role in reducing the risk of medical emergencies in the dental practice, and it's therefore recommended that all primary care dental facilities have a process for medical risk assessment for their patients. Anticipation of potential medical emergencies that may arise should be highlighted by taking a thorough medical history, which is revised, updated, and checked each time the patient presents for treatment. It's been suggested that the presence of an updated medical history may help to minimize the risk of a medical emergency occurring. According to the American Family Physician Journal, a medical consultation in preparation for a dental procedure should include the patient's medical conditions, treatment plans, and current levels of management, any resuscitation directives, and any history of therapy with bisphosphonates or any anti-resorptive drugs. Anti-angiogenic drugs, or head and neck radiation. A history of orthopedic joint replacement is not an automatic indication for prophylactic antibiotics, and physicians should consider discontinuing routine procedural antibiotic prophylaxis after discussing risks and benefits with patients. Consider postponing elective dental treatments for 6 weeks after myocardial infarction or bare metal stent placement and for 6 months after drug-eluting stent placement, and consider optimizing a patient's oral health before initiation of chemotherapy or head and neck radiation to avoid adverse sequelae. And that's just some general guidelines or information that I found to kind of summarize some of the major risk points in our profession, right? So the basics having been kind of established here, I want to clear up and kind of hear from you, what exactly are the most current guidelines for prophylactic pre-med regarding total joint replacement and endocarditis? So these have been changed, I'm sure, several times as you've been practicing, and definitely several times in the last 11 years that I've been practicing. And I want to make sure that we're all completely up to date and on the same page.
Well, I'm really happy to be with you, Brittany. I think this is an awesome opportunity to sort of continue to foster conversations that we have within our practice and sort of, lean on each other's experience and also, knowledge base and resources to sort of like clear up areas that are confusing. And given that multiple different organizations weigh in on a lot of these decisions and a lot of these recommendations, and sometimes can be confusing. I always try to start with the organization or governing body that is most closely related with a given condition that we're helping to manage. So for instance, with prophylaxis for endocarditis, I go directly to the American Heart Association guidelines. They haven't changed dramatically in the last couple of years, but during my practice time, we went from pre-medicating patients who had mitral valve prolapse with regurgitation to a more conservative opinion, which is now the standard, which is there are only 5 conditions where there's a current recommendation for pre-medication for infective endocarditis prophylaxis. And those are a unrepaired cyanotic cardiac condition from birth, a repaired cyanotic cardiac condition with artificial material, which also falls into the 3rd category, which is a valve replacement with an artificial valve. The next condition is a history of infective endocarditis, and the last is a cardiac transplant. What can be confusing is that different organizations will have variations of these recommendations, but I think you can be safe in focusing on those 5 as your baseline before any dental care.
Okay, so none of it anymore is regarding joint replacements, or is what you just is that a separate kind of section?
Right, that's a separate section. So those are the American Heart Association guidelines with regard to cardiac conditions that require pre-medication with an antibiotic.
Got
it. When we're looking at pre-medication for a joint replacement, the recommendation historically has been a little bit confusing, even to those of us in who've gone to medical school. The main governing body for the orthopedic surgeon is the AAOS, American Academy of Orthopedic Surgery. They've condensed the recommendation into a tree of options, and I'm sorry it's black and white, but you can actually go on their website, aaos.org. And there's a care decision tree as to what's appropriate versus maybe appropriate and rarely appropriate for pre-medication. And I try to simplify this in my mind a little bit. If the patient's less than a year out from their surgery, there's in general an elevated risk of infection that could affect the joint. So there's a lower threshold for pre-medicating. The recommendation is for patients that are at heightened risk for infection, so an uncontrolled diabetic, or a diabetic with an unknown level of control, they recommend more strongly pre-medicating the patient. After a year, those recommendations become less stringent in terms of the importance of pre-medicating. So I think for the use of your, for the benefit rather of your listeners, under a year's time, I would always lean on the recommendation of the individual orthopedic surgeon. After a year's time, it's less of an importance unless there's some underlying health issues that would put the patient at increased risk for infection or more serious infection.
Got it. Okay, thank you. That's a really helpful summary, actually, and probably the most concise one I have heard, because it does get very hairy regarding the governing organizations and who to go to for what particular thing. So thank you for that. My next question is, what are the most common medical emergencies that you have encountered in your practice?
Along the lines of what you had mentioned, syncopal episodes are probably the most common thing that I've seen in the practice, which is in line with sort of the data that you presented. Syncopal episode, if you try to look at the basic biology of the process, is a decrease in blood flow to the head and ultimately to the brain. The body has mechanisms for compensating for decreases in blood pressure, which include increasing the heart rate, constricting the peripheral blood vessels to get blood to the brain. In a syncopal episode, you have to think of it as the pump is not working as effectively, so the heart rate is slowing down, and that constriction of the blood in the peripheral part of the body, in the legs in particular, has decreased. So you have vasodilation, basically blood collecting in the veins and the extremities. All that has the impact of decreasing blood flow to the head, and that leads to, the experience of fatigue, restlessness, pale color to the patient, and potentially loss of consciousness.
Gotcha. So we have all obviously taken basic life support. It's required for us every biennium. So how can we treat, well, actually, let's do this. Since we're talking about syncope now, what does it look like when you are managing a syncopal episode? Like what is the first thing you do? What are the easy practical steps that we can take? And then the follow through that we should do to treat that?
I think the first thing is an awareness of the situation. So you're constantly monitoring, watching your patient. So you'll see that they can get sweaty, they'll lose color, they'll express confusion or be unsettled. Immediately in that situation, we're trying to compensate for that pooling of blood in the extremities. So you want to lay the patient back, elevate the legs, basically put the head lower relative to the legs, and try to physically shunt blood back to the head. Also, you want to protect the patient from injuring themselves. So very quickly, within the first 15 to 30 seconds, the patient can manifest some symptoms almost like a seizure, and can have constriction of the extremities, shaking, movement. Unlike a seizure, this is pretty short-lived, as blood is then beginning to return to the head once you've laid them flat. So in the dental chair, obviously we can put them back in the chair and put something under the legs. If they're sitting in a chair or at the doorway or out of your chair, then laying them on the floor carefully would be the most important thing.
Okay, and then when they come back, like what are the most safe things, the most practical things we can do to make sure that they are okay before they leave the practice? And how should they leave? Should they then have a driver? What does the follow-up look like, the follow-up phone calls, and so on and so forth?
For most of the basic problems we face in the office, monitoring them for at least half an hour is a good starting point. If you have a monitor available, like we do in the oral surgery clinic, we can monitor their vitals, keep a good record of what's going on. In general, with vasovagal syncope, they'll recover pretty rapidly in the first 10 or 15 minutes. But it is important to monitor them and have someone with them. And if they drove themselves to the office, having someone else drive them home, another family member come to see them, I think would be a good idea.
And then, like I was saying before, we've all taken basic life support. So we know how to treat, someone who is choking or someone who has suffered cardiac arrest. But I want to talk practically about what we can do when some other common medical emergencies happen. So we already kind of covered the syncopal episode. But what if someone is suffering hypoglycemia? Like, what do those steps look like in our chair, in our practice?
A lot of this starts with a good medical history. So if a patient comes in and has given you a history of diabetes, recent changes in their diabetes medication, or episodes of having become hypoglycemic previously, you have to have a low suspicion that could be what's happening in your chair. If they're experiencing confusion, and just an uneasiness, oftentimes asking the patient whether they've had food that morning, or what their diet has been like, or what their medications have been like, is a good starting point. We use the term making the patient sweet, but giving them some source of glucose in that situation is always a low risk intervention in a setting where you have a suspicion that hypoglycemia could be a contributing cause of their symptoms. And then your options for that, obviously, in your emergency kit, and I brought one from one of my offices here. You may have a tube of glucose that you can give to the patient. It's important ahead of time, though, to read the directions, because I didn't realize oftentimes they can vary. In this particular tube, the recommendation is to basically give the patient the full tube of paste into the mouth and have them swallow that. Other options would be, a sublingual glucose tablet, or potentially a liquid as well. But if you have something like this in the office, it's a good starting point.
Okay, and then what do some of like the early and progressive signs look like when someone might be suffering hypoglycemia?
Initially, it's going to be confusion, altered mental status, diaphoresis, sort of like sweating, as we had experienced with the Syncopal episode. So that's where the confusion lies, sometimes in differentiating between the two. In general, hypoglycemia is a slower onset process than vasovagal syncope. So that's how, between the two things that we've discussed so far, just the timing, in my mind, would send me in one direction versus the other.
Okay, thank you for clarifying that. Let's move on to a seizure disorder, or someone is having a seizure in our chair. How can we recognize? I know that there are a lot of different types of seizures. Some of them are more overt and some are more covert. So what signs and symptoms can we look for regarding seizures and preparing for someone who potentially is going to have a seizure? And then kind of walk us through managing an episode like that.
The majority of our patients that have are likely to have a seizure in the office are those that have a history of seizures, and many of those patients are already being followed or managed. So again, we're starting with taking a good history, and if the patient states that they've had seizures in the past, you can ask what are their triggers, what type of symptoms have they had, how has it been managed, what medications they're on, and to what degree they have a level of control of the seizures. There's a range of symptoms that can be associated with seizure, extending from the tonic-clonic type seizures where there's rigidity and movement. In cases where there's a lot of uncontrolled movement of the patient, protecting them from injury is the most important thing. Recommendations have shifted away from any type of intervention for their airway in terms of placing anything in the mouth, or the main thing is getting anything out of the way that would potentially injure them, such as dental instruments or a tray or arms of our chair that may be extended over them, and just making sure that they're in a position where they're not likely to fall or become injured if they're beginning to move more so than as the seizure progresses. And then on the other end of the spectrum, you have seizures like obstinate seizures, where it may just be a level of confusion or dizziness or a lack of responsiveness. And with all of those, again, it goes back to just protecting the patient from getting injured, and most of them are self-limited. If you have seizures that are progressing, though, or not stopping after a short period of time, 15 seconds, 30 seconds within the first minute or two, then you want to have a low threshold for calling for EMS support.
Okay, got it. And I'm assuming it's discretion, like it's the discretion of the healthcare provider, or correct me if I'm wrong, to call emergency medical services. Like, is that always indicated, or is it sometimes indicated, or does that the person who is seizing have the option?
It's ultimately up to the provider in terms of what you feel is in the best safety of the patient. And regardless of the extent of the history or how frequent the seizure was, if you have any concern that the patient was injured, had any head contact in a rough way or any type of fall, or if the seizure episode is continuing on longer than you feel comfortable, or they're having any other associated symptoms in terms of continued confusion or breathing problems, then I would have, like I said, a really low threshold for calling 911, calling EMS to have some backup and support.
And we know that a lot of people who, moving on to the next thing, just thinking regarding allergies and reactions to things that we use commonly in dentistry. I know that a lot of people know what their allergies are, and if they have a severe reaction, or they, have I think it's a type 1 reaction, anaphylaxis, is that correct? Yeah, so if they have a type 1 reaction to a certain allergen, they usually know that and have an EpiPen and are prepared for that kind of instance. But, in a case where that is the case or not, if a patient isn't identifying it or can't identify it in time to get their own epinephrine, like how can we then address that emergency?
So if a patient has a history of an allergic reaction, we're talking about the type 1 or fast onset type of allergy that could potentially lead to what's most concerning, which is anaphylaxis, which is a systemic response that can impact their airway. Having the patient bring their own EpiPen obviously would be a good start. They may need assistance in administering it though in the midst of that episode. So one of the things I really encourage my whole staff and obviously your listeners as well is become comfortable with sort of the range of epinephrine administration products that are available. And obviously EpiPens were not as available in the last few years. So they come in all different shapes and sizes. And in some of your emergency medical kits, it'll actually even come as a vial. So in the office that I was in today, it comes in a small vial that you have to draw up yourself. So you have to know how much you're going to draw, and then how to do that in an emergency setting is going to be really challenging and stressful. So you have to know how much you want to draw up and how you're going to administer it, as well as where you're going to administer it. A lot of the EpiPens will come with a trainer, and this is sort of a different version of the traditional like pen version. But I would definitely recommend trying it out. And there are EpiPens that don't have needles in them that allow you to sort of get the experience of administering it, because you want to make sure the dosage is administered to the patient when you want it to be.
Well, I was going to ask, are there any resources you'd recommend, like for us to, like, there's got to be resources on YouTube or something as to how to learn the dosages and how to make that determination, or like, where can we get some training on that?
Basically, most of your BLS type courses, I believe now will cover some of that, but a great resource for everyone who has a question in any area of medicine looking for a data-driven and peer-reviewed type of information source is uptodate.com. And that's where I go for information for my patients if it's an area of something that I'm not familiar with. And I think that's a good starting point for this info as well.
Okay, thank you. So that was uptodate.com. Thank you so much. The next thing would be angina. And I know that angina, there are different types of angina. I've suffered from what we think is, I think, called Prinzmetal's angina or something like that, where it's like kind of, we don't know where it came from. We don't know the etiology, we don't know why it's happening. There's no like negative repercussion or outcome. There's no physiological reason for it that can be seen on any sort of blood work, X-ray, MRI, and any sort of screening tool or test. But if someone is suffering from chest pain or angina, what do we typically look for besides the person saying, I have chest pain? And I would assume this is always a situation where we would call emergency medical services, because we can't diagnose and assess further than what the person is experiencing and their signs and symptoms, right?
It all goes back to a good history. So a lot of your patients who have a cardiac history or a history of chest pain in the past may have something called stable angina, where periodically they're developing symptoms that are characteristic to their particular condition. So the challenge is that may manifest as jaw pain or shoulder pain or chest pain or back pain. There's a whole range of symptoms that may be that fall into the area of angina. Those patients oftentimes will be carrying their own nitroglycerin tablets or on medication to help with that. In a episode of acute chest pain that's consistent with their underlying condition and their disease process, giving them one tablet of nitroglycerin and monitoring them for response to that is a good initial step without having to immediately initiate a call to 911. Most patients that are under good control will respond to that, and that potentially can be the end of the episode. Obviously, you want to encourage them to follow up with their primary care doctor, or their internist, or their cardiologist. However, if they don't respond to that initial dose of nitroglycerin, after 5 minutes, you can administer a second dose. But in my practice, I would immediately initiate call to 911 in that situation, just because you have to have a low threshold for a concern for a heart attack developing.
Okay, so moving on to, go ahead. Did you have something else?
I was going to say, for the patient though that's developing symptoms for the first time, that you can, if you have any concern for heart attack, in your elderly population where they're having these sort of non-specific chest pain or pain radiating to the shoulder or the jaw, sort of like the administration of glucose, giving the first dose of nitroglycerin. If there's no history that would be, limiting to you doing that, is a low risk intervention. But in that situation where there isn't a history of chest pain and they have risk factors for a heart attack, I would, again, be very quick to dial for EMS and 911 in that situation, which is different than the stable attention of patient.
Okay, so regarding medical clearance we're talking in our realm about treating patients more invasively in hygiene. So we're not talking about, major surgeries and extractions or, like full mouth reconstructive sort of cases. Who needs a medical clearance? Like, the patients I can think of off the top of my head are patients with a history of head and neck radiation, patients who are currently undergoing chemotherapy, patients who are on immunosuppressants, have bleeding disorders, uncontrolled diabetes, or HIV. Pregnant patients. Is there anyone else, or is there any kind of easy way that we can remember how to remember which patients we need to get a clearance for?
I think a lot of times we have to take a step back and look at what's the overall picture of the patient. Do they look like they're being well managed and followed? Are the medication lists that they're giving us up to date and accurate, and are they giving you a good reflection of their overall health and stability of the care that they're receiving? So oftentimes patients are coming in and they don't know what medications they're taking, or their blood work was just fine, but it's we don't really know. And in that situation, giving a call to the nurse practitioner that's taking care of them, or the primary care doc, may be worth it, especially in the elderly population that we're serving in South Florida, for instance. Likewise, on the other end of the extreme, for very young patients, if you're dealing with patients with special needs, or patients that may have underlying cardiac issues, in a pediatric practice, the same thing applies there. If you're not getting a very clear history, I would have a low threshold for picking up the phone and calling the pediatrician. Most of the conditions that you mentioned are what we see in practice: the diabetes, the hypertension, the bypass surgery. The patients that are at increased risk for poor healing, generally are in those categories of uncontrolled diabetics, patients that have received chemotherapy recently, or ongoing care for a host of more complex conditions that they're seeing specialists for. Any patient that falls into those categories, I think I would have a lower bar to go ahead and send a medical clearance if you have any question or confusion.
Okay, yeah, and generally that's my rule of thumb, is to go on the safe side. If I have any question or concern, I reach out to the person's practitioner. Okay, so the list was pretty inclusive then. Those are really the things.
When we're in training and assessing patients for anesthesia, we use something called ASA classification, where it ranges from patients who are ASA 1 with no significant health problems to more advanced conditions. So you go on to ASA 2 with well-managed conditions, and then ASA 3 with potentially multiple conditions or poorly managed conditions. And I think that's a nice sort of global view of categories in the patient populations that you really need to dive into potentially getting medical clearance, or those that fall into the ASA 3 type category. For practical purposes, that generally would include, as you mentioned, your uncontrolled diabetic, your cancer patient, or your hypertensive or cardiac patient who's on multiple different types of medications or blood thinners. And then obviously your patients who are on active chemotherapy or recent chemotherapy.
And then what are some of the most common postoperative complications you see in oral surgery, or that occur in more advanced dental or hygiene procedures like scaling, or like the full mouth, or like, different things that we do?
Especially with the recent increase in availability of easy to manage medications for coagulation or clotting problems. So patients that have a history of DVT, deep vein thrombosis, or PE, pulmonary embolism, or have any type of valve replacement or cardiac stent recently, you'll frequently see patients on a whole host of what 10 years ago were called novel oral anticoagulants. So these are your Xareltos, Pradaxas, Eliquis type medications. As well as your older medications, which fell into the Coumadin or warfarin family. With all these medications, they increase the risk of postoperative bleeding, which is oftentimes the most common thing that we see in the day or days after an oral surgery procedure. But you can also see with deep scaling or periodontal therapy that you guys may be providing. It's important to sort of anticipate which medications are going to have an increased risk for this. In my experience, patients that are on dual platelet therapies, meaning that they're on an aspirin plus a Plavix or another medication in the Plavix family, they may have some prolonged bleeding on the day of the surgery, but then in general, once the bleeding stops, you're not encountering bleeding days later. The challenge with the newer medications, such as Pradaxa or Eliquis or Xarelto, which don't have to be monitored, is that in my experience, some of these patients will end up having bleeding even 1 or 2 days or a few days later. So you may get a call that the patient's continuing to bleed, 2 days after they had their deep scaling. And what do you do in that particular situation? A good assessment of how much they're bleeding, and then what they've been doing, or even reach out to their physician in terms of what can be done is worthwhile.
Okay, and generally for something like a scaling, would you recommend reaching out to the person's physician to see if they should discontinue the Pradaxa or their Eliquis or whatever it is prior to that procedure? That's not something that I learned in hygiene school. It's not information that's readily available to us or recommended necessarily, but being that we're leaning toward, the low threshold for some of these things and being on the safe side, is that something that you would recommend generally, or is that not something that is indicated at all for a procedure like scaling, but more so for a more major procedure, a more invasive procedure?
Yeah, I think what you just said is a good starting point. Even when you're calling to speak with the physician, you need to be able to give them a good assessment of how much surgery you're going to be doing. There's a big difference between doing 4 quadrants of osseous surgery or scaling and root planing versus 1 quadrant or a localized area of scaling. So one is what is the risk of postoperative bleeding from the surgery itself, and then there's an assessment of the patient. So I even had a patient today who had a history of PE, and a pulmonary embolism is a high risk complication. So with a history of having multiple pulmonary emboli, I'm going to manage the bleeding versus take the risk of manage a potential risk for increased bleeding versus taking the risk of a patient having a pulmonary embolism. If the patient has a history of atrial fibrillation and they're on one of these medications on a purely preventive basis, meaning that they haven't had a clot, they haven't had a stroke, then their physician may be willing to take them off of the medication for a procedure that's going to be more involved, like 4 quadrants of scaling and root planing. So I think it's a dialogue that has to be had with the physician, but you have to know entering that request for clearance that you're giving them the information they need to give you a recommendation in terms of what to do with the medicine.
Okay, got it. So when in doubt, just defer to the physician, just make the phone call, pick up the phone, have a dialogue, is what it sounds like.
Yeah, and historically, the recommendation has been not to take the patient off of these medications, with few exceptions. But my experience, having gone to both dental school and medical school, is that a lot of physicians don't really have an understanding of the extent of procedures that you or I may be doing for the patient. And once that's been clarified, they may be more apt to work with you in terms of a plan for managing their coagulation medication.
We know the answer to this question, but I'd love to hear it reinforced by you. What would you say the best what is the best way to prevent medical emergencies in a dental practice?
A good plan. So it starts out by knowing your patient, getting a good history, having a good assessment of, what their overall state of health, and then also what, what potential problems could happen, and then also having a plan for managing any plans that could come in. We didn't go into it, but airway issues or worsening symptoms of asthma is really common this time of year. And knowing where your albuterol is and having that available and readily available for a patient who's having an asthmatic episode is critical. And those are very basic things. If you have oxygen readily available in the office, how do you use the regulator, the controlling valve on the oxygen tank, and how is it set? And like we had talked about with administering epinephrine, do you have an EpiPen or do you have a vial of epinephrine? How do you administer your glucose? All these things are critical ahead of time and really practical. You're more likely to be using, the medications that we just went over than you are to be doing chest compressions in your office. And that's why sort of having an emergency plan and, reviewing it along with your team so that you're all comfortable with how to address an emergency is really critical.
Okay, and then what are some of the most questions we can ask patients on a medical history to reduce the risk for emergencies?
Like we had talked about, ask follow-up questions. So when you get your medical history back and they say, I have a history of asthma, you can ask them, so what medications have you taken? How frequently are you using your inhaler? Have you had any hospitalizations or episodes of asthma in the dental office or in other settings? We talked about chest pain. What are your symptoms? How have you managed them? How do you respond to nitroglycerin? Those types of questions. So ask follow-up questions when you see a patient has listed, a medical condition, especially something that may pose a risk in your office. Then I always frequently patients will come and see me and say, oh, I don't have any medical problems. And then I look at their medication list and I see they're on 5 different medications.
Mhm.
So that's really important as well. Follow up with the question, even if they say I have no medical issues, ask them what medications do you take regularly or what medication should you be taking? Because oftentimes also they'll say, yeah, I was on a blood pressure medication, but I just stopped it for insurance reasons or decided that I didn't like, the side effects. And maybe they should be on be back on that blood pressure medication. So that's a really helpful area. And then also go through the rest of the medical history. Have you been recently hospitalized, especially in the older population that we're working with? And if they come in with an aide or a family member, if the patient's comfortable asking with you involving them in the conversation, they may be able to shed some light on sort of like their general health status and how they've been doing. Maybe they can't sit through an hour surgery, and maybe a shorter procedure is what's really indicated for that day.
Got it. Yeah, I sometimes think that patients interpret the question, do you have any medical conditions, as what is currently hurting you almost. It's like if their problem is currently being treated by medication, I think that they see it as not a problem any longer. They no longer have high blood pressure because they're taking, a diuretic or whatever their high blood pressure medication. So it's just funny how patients do answer that question, and it's always good to ask open-ended questions and ask them to elaborate when in doubt.
No, I was just saying, and then right after that, also, always take a global look. So we can get hyper focused on the teeth or the head and neck. Frequently I've had patients come in with a recent dressing on their knee from their joint replacement that happened 3 weeks ago, and they've decided they want to go ahead with their dental care. I'm like, so how long ago did you just have your knee surgery or your total joint? Patients are getting out of the hospital really quickly and back to activity now, so they feel that they're fine, and they may just have had a cardiac procedure or a orthopedic surgery that's going to immediately stop us from being able to do anything that day. So I always take a look to see if there's anything that sort of like also would prompt me to ask a follow-up question on your exam as we're walking in.
That is a great point. And this is related but unrelated. Like, I know that I personally have had the same experience. In fact, recently I had an experience like that. And it was one that I consulted with you on because I wasn't sure about the guideline, which is kind of what initiated this podcast, actually. But I dismissed that patient too, because it was in the first 3 months of them having a total joint replacement as well. And he couldn't receive prophylactic dental care yet, So that was, it's interesting how, even though I asked the patient, is there anything new with your medical history, meaning any changes to your medications, newly discovered allergies, any recent surgeries? Like, I specified that, and it was no, because I think in patients' minds, it's not my head or my neck. So it's not related to my mouth or what you're going to do for me today. So it is good to have that global kind of view of the patient. And similarly, I have looked at patients, someone's arm toward me, someone's ear, they have basal cell, they have squamous cell, they have something going on their skin. And I'm just like, hey, what's going on with this? Do you see a dermatologist? And get curious about what's going on. And more often than not, just questioning, you're going to eventually get to the bottom of it, even if it means referring to a specialist, and it's obviously not in my wheelhouse to treat a squamous cell issue or a dermatologic issue, but if we can identify those things, we can save patients from a lot of pain and suffering, And the first thing, our first golden rule is do no harm before do good. And that's what it takes to do no harm, is curiosity and the ability to observe and really see our patients globally and as a whole person. So thanks so much, Dr. Sheikh, for being here with us today. I really appreciate that you spent time with us.
Thanks for having me. It was a great conversation.
Awesome. Thank you. And thanks for everyone for listening this week. Please feel free to connect with us further by downloading the Mighty Networks app and searching Bulletproof Hygiene. Our live annual summit is also approaching rapidly. It's taking place this year in Vegas on August 11th and 12th. If you want more information on this incredible 2-day event, go to bulletproofsummit.com. And there you'll see information on summit topics and sessions offered, as well as group rates and how to register. It's an event for the entire team, from hygienists to doctors to assistants, administrative team, and office managers. We have heard some game-changing and life-changing stories post prior summits. So we really hope to see you all there, and we'll see you next week on podcast.